So in our second lecture on ventilation and perfusion, we're going to look at some disease states. So this is just a reminder of the case we're looking at, and we'll discuss a little bit about this during this lecture. So we're going to focus on obstructive lung disease and some other disease states, really looking at the principles behind what happens in these diseases. So we are going to take this in terms of diseases that affect either ventilation or perfusion or a combination of both. So let's think about somebody with global hypoperfusion. So they're in shock. The entire lung is being underventilated, because in the normal lung the apex is better ventilated than perfused. Then any global hypoperfusion will affect the apices more than the bases, and to add to that, the heart is still working against gravity, so there's an even greater increase in the mismatch between ventilation and perfusion. Perfusion to the apex of the lung in the shocked patient is going to be even less than perfusion to the base of the lung. There's going to be an even greater decrease in perfusion. So the dead space at the apex of the lung becomes worse, and therefore the ventilation perfusion mismatch at the apex of the lung becomes worse. Bear in mind that any discrepancy between ventilation and perfusion, one way or the other, reduces the efficiency of gas exchange. With global hypoventilation, the reverse happens. With global hypoventilation, because the ventilation is maximal at the base, because with reduced ventilation, at the base of the lung, there's an even greater mismatch between ventilation and perfusion at the base of the lung. So as the lung becomes hypoventilated, because the maximum amount of movement of the lung is at its base, when we're breathing less, we have a greater decrease in ventilation at the bases compared to the apices, just because there's less variation in ventilation at the apex of the lung. So the base of the lung is more hypoventilated, and we already have an increase in perfusion from the apex to base. So therefore the discrepancy between ventilation and perfusion is greatest at the base of the lung in a patient who is hypoventilating, and therefore there's an increase in shunting. On top of the poor ventilation, as we hypoventilate, there's an increased risk of atelectasis in the bases, which would further exacerbate this discrepancy between ventilation and perfusion, and therefore there's an increase in the amount of shunting at the bases of the lungs in the patient with global hypoventilation. So let's think about what happens with regional changes. So global hypoventilation would be a patient with CNS problems that isn't breathing properly, or a patient with neuromuscular problems that can't use all of their ventilatory muscles, or patients who have taken an overdose of a tablet that suppresses ventilation. Let's think about regional hypoperfusion. So regional hypoperfusion will cause regional areas of increased dead space, areas that are ventilated but not perfused. So an example of a disease that causes regional hypoperfusion is pulmonary embolism. a pulmonary artery is blocked and that area of the lung is hypoventilated. So initially that would cause an area of dead space, an increase in ventilation perfusion mismatch, areas that are ventilated but not perfused. But the human body finds a way to try to adjust for this. And areas that are hypoperfused after a while there's a regional reduction in ventilation in those areas due to a combination of bronchospasm and atelectasis. And this is an attempt at the body to match ventilation and perfusion. So in fact, it's more efficient for the body to shut down areas of hypoperfusion and not ventilate them, because that's already wasted ventilation, and that does happen through these mechanisms of bronchospasm and atelectasis. We'll see in the next lecture how that affects us then providing mechanical ventilation in this situation. Similarly, if we have areas of regional hypoventilation, so a patient with pneumonia, for example, or a patient with ARDS and areas of hyaline lung, or areas with pulmonary edema with the alveoli filled with fluid, those areas are not ventilated. And again, the body has a reflex mechanism to match ventilation and perfusion. So in this case, you have poor ventilation but initially normal perfusion leading to shunt. But those areas that are badly ventilated, there's a reflex regional vasospasm in those areas, and therefore the areas that are hypoventilated are now also hypoperfused. So we have a matching between ventilation and perfusion, and that improves efficiency of gaseous exchange because we're not wasting blood flow to areas that are not being ventilated. So when you have regional hypoperfusion or regional hypoventilation, the body has ways of matching ventilation to perfusion and shutting down the other aspect in that area. So if you have poor ventilation, perfusion will be shut down. If you have poor perfusion, ventilation will be shut down. And this is the way of the body trying to compensate. So when we apply positive pressure ventilation to patients with regional hypoperfusion or regional hypoventilation, we can make things worse initially because, for example, in a patient with regional hypoperfusion, we now force ventilation into that area, and at least initially that area is not being perfused, but we're ventilating the area, which then leads to creation of dead space once more. Whereas in the patient who had poor ventilation of some parts of the lung, those parts would have reflexly shut down the perfusion. When we start ventilating those parts of the lung initially will not be properly perfused until the body has a chance to adjust. So this is why when we ventilate patients with ventilation perfusion mismatch, often their oxygenation gets worse because the VQ mismatch gets worse transiently until the body can adjust again. So if you have any questions about what we talked about in this lecture, you can bring them up in class and we'll discuss them. So in this lecture, we looked at variations in ventilation and perfusion in different disease states. In the final lecture, we will look at positive pressure ventilation.